Dr. Diego Marinas, ASCRS again, San Diego, 2025. And my understanding is you're on the innovation committee, is that correct?
Yes, I'm on the new technology committee for this Congress.
And what does that mean? What do you guys work on there?
We get submissions from a lot of surgeons, residents, and fellows about new things they are trying in their practices, and we evaluate them to see which ones of those will be valuable for the whole Congress to see at our new technology symposium, which actually is going to be tomorrow evening. It's very well attended.
Really? Is there anything particular that you guys are going to be discussing from this tomorrow that you can let us in on?
You have to be there to find out.
Well, I would say if you're talking about cutting edge stuff or new innovations, I think colorectal surgery is one of the first ones. They've really taken up the robotic world. Yeah. And my understanding is this is something that you are very interested in, you've been doing a lot of work with, and you've already been working with the DV5 now for a period of time. What has been your experience with the new platform?
It's been great. I've been on about 30 or 40 cases on DV5, and now every time I go back to using the XI, whenever someone else is using DV5 at my institution, I notice the difference right away, starting with the visualization. Like the scope on the DV5 has so much better visualization and clarity that it's something like you didn't even know you needed until you've been using it and getting used to it. So that's number one. But the efficiency, what I've noticed, the most important thing I've noticed is how much more efficient I am. I'm saving 14.5% of the time, of the total OR time with DV5 compared to my XI cases. I attribute that to the guided instrument exchange, because my assistants at the bedside that were not experienced laparoscopists sometimes would take a little bit longer to introduce the instruments and finding where to go. With a guided instrument exchange, it's so easy for them, and it's right there.
I don't use DV5 yet, so I've been on the XI, and I'm not clear what is different between the guided instrument change now versus the exchanges that we had on the XI.
Yes, there was some type of guided instrument exchange on XI. For example, if you just wanted to extract one instrument and introduce a new instrument, the green light would blink on the console, on the robot itself, and you would just push it in. However, it didn't tell you where the tip of the instrument was going to land. You would just have to trust it. And on DV5, there's signals that tell you exactly where the tip of the instrument is going to land. And also, if something changed, maybe the bowel moved a little bit, then it detects that. I haven't used that feature, but I think it detects that, and it keeps you from poking the bowel, for example.
So it's actually, from a safety standpoint, it's going to prevent you from going through a piece of tissue that you didn't expect to.
Yeah, you introduce those instruments with so much more confidence and efficiency that it's crazy efficient.
Yeah, you're not the first person to bring up the efficiencies of it. Is it just the instrument exchanges, or what else are you seeing increase in efficiency?
No, the head-in controls. I am a big proponent, as part of my enhanced recovery after surgery pathway, of low pressure pneumoperitoneum, for example. I operate sometimes at 8, 9, or 10 millimeters of mercury, and that's the first thing I do. I get on the console. Once they introduce all the instruments, without having to take my head out of the console, I just go into the head-in menu and decrease the pressure myself. Right?
Oh, so this is all heads-up display now?
Yeah. The circulating nurse doesn't have to walk all the way to the insufflator that you're using to decrease the pressure anymore. That saves time.
But even then, the display is actually in the monitor. You don't have to pull out and look down at it.
You don't pull your head out to look at the menu there. It's in the view. Yeah.
When can they put my playlist off my phone into the heads-up display?
Oh my gosh! I'm sure they're going to be able to do that. Yeah.
Now, so you've seen that. Any other areas you've seen the efficiencies improve?
Yeah, other than changing the pressure, you can also change the orientation of the camera, tip up, tip down, without taking your head out. When they introduce a new stapler, and you have to select the color of the load, you can select it also without taking your head out. Blue, white, green, whatever load you're using. And other things like that as well.
What about the rest of the interplay? Because it's got a whole system now built in with it. So you can do telepresence or...
Oh yes, I am a big user of telepresence, which is included with DV5. My Intuitive Plus is a whole platform that encompasses telepresence with DV5. And I'm the busiest, actually, case observation site remotely for colorectal surgery. And we have surgeons live streaming my cases to their office or to their home frequently from all over the world. We've had surgeons from Canada, South Africa, India, etc., and the US, of course. And not only they can stream them, but they can interact with me. And I have a headset while I'm operating so that we can talk back and forth. They can ask questions. I can narrate parts of the procedure. But also, which is really, really interesting, is with their mouse on their computer, they can actually telestrate. And I see what they're pointing with their mouse. I see it in the console without taking my head out with the help of Tile Pro.
How difficult is it to set all that up?
It is not very difficult because DV5 is set up for that. However, the process of having the institution, the hospital, get all the approvals needed, the legal and the IT, it takes several months. But once it's set up, it's so smooth. It's really good.
So it's good to tell a surgeon, like, don't just expect that you're going to do this and not talk to your institution, but make sure that they're on board.
That's a great point. That's a great point.
All right, because I've definitely been one of those that I'll just go do things and then ask later, but that's probably not the way to go here.
Yeah, it wouldn't work.
This episode of The Cutting Edge with special guest Dr. Diego Marinas will return after this.
On top of that, you said you were using the new stapler as well.
Yes, I have been very pleased with the new 8mm stapler. What port hurts the most, as you know? The 12mm port, right, for the stapler, because you have to close it at the fascia. The new 8mm stapler, which is actually only 30mm in length, so it might take you a couple more fires for the entire case, for a right colon, for example, but it eliminates that 12mm port. So that for me is a game changer, and the patients have much less pain. And I use it. The only difference that some surgeons don't feel very comfortable with is that instead of 3 rows on each side of the blade, it has 2, right? So it takes some getting used to. You use it first on very straightforward cases, and then now I've used it even on the rectosigmoid to do a sigmoidectomy with no problems at all.
Yeah, I have to wonder, because if I remember right, the EEAs only have 2 rows, don't they?
I believe they have 3. The regular endo cutters, I think they have 3 rows on each side.
And then the endo cutters, I don't think the EEAs may only have 2.
Oh, the EEA, you're right. The transanal stapler, yeah. 2 rows, I believe.
Yeah. And with that, you've incorporated ERAS directly into your whole system?
Yes.
Yes.
Seamlessly. I had already been doing ERAS for years. In 2022, I decided to start doing the next step, same-day colectomy. So now 45% of my patients go home the same day after a right colectomy, a sigmoid colectomy, sometimes a low anterior resection if they're not going to need any stoma, if they're not radiated. So the main thing is selecting the patients appropriately.
And how do you do that? How do you go about, if I was going to sit down and say, you know what, I want to add ERAS, I want to take the robotics to the next level, and I want my patients, if I can, to get home same day. What would that look like from my perspective to start to end to build that out?
Great question. First of all, education of the perioperative area. The PACU nurses, they're used to discharging the patients from PACU very quickly. So now we're going to ask them to keep the patients there for a few hours to meet the milestones, which are they have to walk around a couple of steps, they have to be able to drink a couple of sips of liquids, and they have to urinate without a problem. So what we do here is we pull the Foley catheter at the end of the case, right, to allow them to do that. And so that's one thing, is education for all areas involved in the perioperative service line. Then we would need to, of course, educate the patient and then select the patients. And we select the patients mostly in 2 areas. In the office, when we see them initially, we see if they don't have heart failure, if they don't have end-stage renal disease, cirrhosis, if they don't live by themselves, if they have good family support, then from that standpoint, they're good candidates. But then in the middle of the surgery as well, we want someone that didn't have a ton of adhesions. We want, if it's a left colectomy, good anastomotic donuts, no leak on the bubble test. So it has to be very well selected. And the great thing is we actually published this data in August of 2024. Of the 45% of the patients of all comers that we discharged the same day, 0% had readmissions or complications because we were selecting and predicting who was going to do great. Of course, we had complications, as everyone does, on the patients that we decided to monitor 1, 2, 3 nights or more.
And when you're setting this up, do you have a very strict, does your staff have an objective list of criteria that you're looking at and then they funnel them one way or the other, or is this something that you've developed and as you're talking to the patient, you're trying to work it through? And also, when you say you educate the patients, what are you telling them?
So it's usually me, because I meet the patients myself in the office, so it's me saying, okay, this is a good candidate. And then I do have maybe resident or nurse practitioner seeing them in the PACU to see if they met the milestone, so they help me also decide. What was the second question?
Educating. So what do you tell the patients about this?
Setting the expectation, right? Oh, my grandmother had this surgery 10 years ago and she stayed in the hospital a week. Am I going to stay a week? And when they tell them you're going to go home the same day, most likely, then they're like, whoa, things have really changed. And you have to, yeah, but that's now what we do. We've done hundreds of cases like this, and it is okay. And you'll do much better if you're home, because mind and body are connected. If you're home, you're sitting in your couch, streaming your favorite show, you feel like you're normal and your body follows, right? If you're in the hospital with a beeping machine and checking vital signs every 4 hours with hooked up to an IV, then your body's gonna say, oh, I'm sick, I don't wanna move so much, I wanna stay in bed. So
perception is reality kind of thing.
It is huge. And it's a phenomenon that I still cannot explain, but the patients that we send home, we haven't had ileus, knock on wood. And ileus is a common thing when you have patients in the hospital.
Now, you probably, because your ERAS protocol, you're limiting your opioid use, I assume?
Yes.
What are you using?
We're big on tab blocks with, we have the privilege of having Exparel. So we do Exparel tab blocks, and then we also infiltrate all the incisions with Exparel prosmarcaine during the surgery. And we give them non-narcotics as much as we can. Tylenol, anti-inflammatories, sometimes Robaxin. And in the PACU, sometimes we have to give narcotics as well. A couple of doses of Dilaudid or fentanyl, and their pain gets controlled, and they can still go home.
And how is it, when you started doing this, what do you tell them to look for that would cause them to trigger and actually give you a phone call in the next 2 to 5 days if they have a problem?
We tell them, the most basic way for me to explain to the patients this is, you have to be feeling better and better every day. If there's one day that you are feeling better, and then you feel much worse, please let me know. And they ask me, okay, what are the possible complications? Of course, a leak, bleeding. And the patients ask, what should I look for? Fever, if your heart is racing, if you have more pain, vomiting, all the things that make you don't feel good, let us know.
And if there's one thing you learned, and I always say this, it's that's not in the textbook, it's a wisdom thing. Like, you learned it from experience, from what you've done, be it clinical, education to patients, whatever it is. What is that thing that you look at and say, I wouldn't have known this if I didn't experience it myself?
I think what I like to tell my students and my residents that I always do is listen to the patient, because I've had several patients that don't fit the textbooks. They come and tell you, I'm having pain here. I've seen other surgeons sometimes. I've had CT scans that show nothing. Okay, well, let's trust what the patient is telling you and not just check them out as their pain-seeking patients, right? So I think listening to the patients is something that I have learned.
I have to agree with you so much. It drives me nuts when I hear providers say they're just looking for medications. Like, I have to assume, I always go into assuming that the pain's real. Yeah. I might not have the answer for it, but I hate to sit there and assume that they're telling me something that's just not true, because I can't feel it.
Why would they do that, right?
Exactly. Like, why are they spending the money to come see you? I mean, it's going to cost you a specialist level, whatever, copay to come see you just to get pain meds. it just seemed wrong.
Right.
But well, anyways, I appreciate your time so much here at the Cutting Edge. I hope you enjoy the rest of your time at ASCRS, especially here in San Diego. It's so beautiful. So
Thank you so much for having me.
Pleasure.